The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. Welcome to SuperCoder.com's webinar, RAC's 5 Target Areas Your Group Needs to Know. My name is Jennifer Gaudreau, and I will be your presenter today. I'm the director of SuperCoder.com, and am a certified professional coder, certified professional medical auditor, and certified pediatric coder. I specialize in medical coding policy for pediatrics, ENT including allergy and audiology, family practice, internal medicine, and pulmonology. In my almost 10 years with the Coding Institute, I have written pediatric specialty alert for 8 years, otolaryngology coding alert for 7 years, and the primary care publications for 6 or more years. I also wrote the ICD-9 study guide for the certified otolaryngology coder exam offered through AAPC, and edited some of their professional instructor 2011 curriculum. I have a Bachelor of Arts in English from Wittenberg University in Springfield, Ohio. I became a CPC in 2001, added my CPEDC in 2009, and my CPMA in 2010. I'm setting my sights on CPCH for 2011. You can download today's handouts from SuperCoder.com conference, where you registered for the audio conference. In addition, I will be emailing the associated AAPC CEU certificate at the end of this broadcast to each attendee. You've got so many compliance acronyms flying at you every day that you may not be able to differentiate RAC from the other auditor terms flying around. Know these quick facts about RACs, NIPECs, and ZPECs to stay better informed. Keep your eye on ZPECs, as their audits may be more liable to close your doors than any other Medicare contractors. The Zone Program Integrity contractors are authorized to use statistical sampling to identify overpayments from providers. That means millions of dollars in overpayment demands can come from a relatively small sample of claims. ZPECs, which are replacing the Program Safeguard Contractors, or PCSs, are organizations hired indirectly or in connection with other CMS-affiliated contractors by CMS to perform a wide range of medical review, data analysis, and Medicare evidence-based policy auditing activities. While ZPEC audits are similar in many ways to RAC audits, they differ in one very important aspect. They carry implications of potential Medicare fraud. Of all the current CMS audit initiatives, RAC audits, NIPEC audits, etc., it is vital that providers facing PSC audits or ZPEC audits immediately and effectively address targeted audit areas. The ZPEC auditors have recently been focusing their efforts on physician physical therapy, skilled nursing facility, and DME supplier billing. While the original RAC operated in the 3 major Medicare states, Florida, New York, and Texas, the program has been expanding. The permanent program splits the nation into 4 regions with RACs functioning in every state. RACs can retroactively deny your claims for a number of reasons, but one that can easily be remedied is lack of medical documentation. If a RAC requests your medical documentation and you don't send it, or you submit incomplete or illegible records, your payments can be denied. Plus, money that your MAC already sent to you can be recovered back to the carrier in cases of non-existent or incomplete documentation. The issue of incomplete documentation was identified by CMS recently as a high-dollar improper payment vulnerability, and the agency issued an MLN Monitors article to discuss the topic and explain to providers that documentation should be a top priority. Coders and auditors should be catching insufficient documentation before a claim leaves the group, but in some cases it's caught by RACs on the back end after a claim has already been reimbursed. If you know you're missing documentation, you shouldn't bill for the service in the first place, or you could have to reimburse that money down the road. MPECs are the Medicaid side of ZPECs. When the program rolls out, MPECs will also look for fraud, but in the Medicaid arena. CMS has delayed the proposed April 1 deadline for states to implement their Medicaid recovery audit contractor programs. The agency expects to announce the new implementation date later this year in the final rule for the program. Out of consideration for state operational issues and to ensure states comply with the provisions of the final rule, we have determined that states will not be required to implement the RAC program by the proposed implementation date of April 1, 2011, the agency said. The Patient Protection and Affordable Care Act requires states to contract with RACs to audit payments to Medicaid providers. In comments submitted in December, the American Hospital Association urged CMS to exempt from the program states with existing Medicaid audit or managed care programs. And states and hospitals that participate in payment reform demonstrations that have conflicting requirements. RACs detect and correct past improper payments so CMS and the MACs can prevent such problems in the future. RACs are hired as contractors by the government, and they can collect contingency fees, which means they can get a percentage of the amount that they recover from providers who are paid inappropriately. The maximum RAC look-back period is 3 years, so till October 1st of 2007, and RACs cannot review claims past that date. Between 2005 and 2008, RACs involved in the original 3-year demonstration project recovered over $1.03 billion in Medicare improper payments, but referred only 2 cases of potential fraud to CMS, according to a February OIG report, which noted that because RACs do not receive their contingency fees for cases they refer that they are determined to be fraud, there may be a disincentive for RACs to refer potential cases of fraud. Your practice isn't the only party in the RAC-provider relationship that has to play by the rules. The RACs are required to stay within the following guidelines when requesting documentation from providers. The RAC must indicate the deadline by which you have to submit your medical records. The RAC must contact you one additional time before denying your service based on lack of documentation. The RAC must indicate the status of the provider's additional documentation request on its claim status website. We'll be looking at that a little bit later. The RAC has to maintain a provider web portal where providers can customize their address and find the correct point of contact. And the RAC must post all approved issues under review on its website. There are numerous ways you can prevent major repaybacks. To streamline your approach to protecting your group, be aware of the currently identified items that auditors will be targeting. The issues stem from the findings of 3 reports, the OIG and the RAC preliminary and implementation programs. RACs are required to publish their target areas. Review which ones are applicable for your care setting and specialty. Take a sample of claims in the affected areas. Internal audits can provide excellent insight into a facility's or a physician's practices, drawing attention to those areas of concern that can be addressed successfully prior to external corrective action. Thoroughly examine the medical record documentation used to code, validate whether coding guidelines are being followed, and finally, compare coding summaries and charge entries to avoid double billing. This proactive approach allows you to identify and correct potential liabilities. That way you can provide education and revise policies and procedures. The audit should focus on the RAC issues indicated. Depending on the code, the overpayments may be due to payments on services for which providers failed to provide documentation when requested or submit sufficient documentation to support the claims, payments for services that are not coded properly, and payment errors including claims paid twice due to duplicate submission. Be aware that if you're doing the audits after payment, You'll need to return the overpayments with supporting documentation and explain the refunds. When you're looking at the findings, check which are applicable for your settings. The major reason for overpayments on the inpatient side are medically unnecessary services. On the inpatient side, the major overpayment areas were caused by excessive or multiple units. The top overpayments by provider and setting are broken down in the table on slide 10. Documentation that did not support excisional debridement was the number 2 source of overpayments on the inpatient side. Incorrect coding of injections cost $5.8 million in physician overpayments. For the outpatient hospital, both hydration and untimed codes cost $5.5 million in overpayments. And that brings us to our first target area that we're going to look at, how to correct IV hydration. The code under scrutiny is 90760, which CPT 2009 replaced with code 96360. Based on the hydration code's definition, you should report this initial code once per patient per data service, unless you have a legitimate reason to append modifier 59. Because you should report only one initial administration code for a single site during the same encounter, you typically should report 96360 only when medically necessary hydration is the lone infusion performed at that encounter. So reporting 96360 more than once on a single date of service is highly unlikely. For hydration services, you should audit at least 30 records. The sample should include old cases, cases between October 1, 2006 and December 31, 2009, recently billed cases from 2009 to present, and pre-billed cases. By selecting these 3 types of cases, you can determine if the coding billing rules that changed effective in 2006 were correctly implemented, whether the coding billing rule changes and those cases are now being coded and billed correctly. 1 is the magic number for hydration units. Only one initial service code, 96360, may be reported per patient per day unless protocol or circumstances require the 2 separate IV sites be used. On rare occasions, a patient can have 2 initial IV hydration procedures. If, for example, the IV in the left arm blows out or has complications and another IV is started in the right arm. Clear documentation of start and stop times is a must to report both IV services. Notation of the reason for the failure of the first initial hydration must be stated in the record. Additional documentation must describe the second initial hydration procedure in the other arm. The time for the first initial hydration service must be indicated as 31 plus minutes. If the initial hydration started at 10 o'clock and stopped at 10:30, do not bill for the service. The second initial hydration can be coded only if it goes beyond 31 minutes. If neither the first nor the second initial hydration lasts longer than 31 minutes, do not code or bill for either one. If a second initial administration code is appropriate, the code should be listed with modifier 59 appended. Using the same audit sample, auditors should validate the following for each case. For all IV hydration, start and stop times must be documented. For hydration infusion intervals of greater than 30 minutes that go beyond 1 hour increments, each additional hour is coded using 96361 with no modifier. IV hydration codes should be billed with chemotherapy codes only if the hydration is given before or after the chemotherapy. If it's given at the same time, do not bill for the IV hydration. Look at claims that contain a chemotherapy CPT code together with an IV hydration code for the documentation of the start and stop times in the record. IV hydration codes should be billed with therapeutic infusion codes only if the hydrations are given before or after the therapeutic infusion. Once again, if both infusions are given simultaneously, do not bill for the IV hydration. You should look at claims that contain a therapeutic infusion CPT code along with the IV hydration code, and look at the start and stop times in the record to determine if both codes should have been billed. IV hydration are not coded and or reported with blood transfusion codes regardless of when the IV hydration is administered. After documentation has been reviewed, auditors should focus on the specifics of IV hydration coding and billing guidelines. If the audit shows that incorrect codes are still being used, check the charge master and charge sheets to make sure the correct codes are listed. Coding and billing of IV hydration depends on accurate and legible medical record documentation. Documentation must clearly indicate actual start and stop times for each bag, the route of administration, and whether a flush or hydration is performed. If only a flush or clearing of lines is performed, the procedure should not be coded unless the flush occurs with medication, which is called an IV push. In these cases, an IV push may be coded. Documentation such as over 1 hour, 600 cc infused with no start or stop times, medically unlikely amounts of medications versus route, such as NS 400 cc per hour flush, initial line removed or HEP block discharged, and administration times that are marked through and are illegible, as well as times recorded that do not make sense. For instance, a starting time with an earlier listed stop time should not be coded and thus cannot be billed. Remember, IV hydration infusions per CPT require direct physician supervision for purposes of consent, safety oversight, or intra-service supervision of staff. The physician should document his or her supervision of IV hydration procedures performed by nursing staff. Be aware that if you're doing internal audits post-payment, you'll have to do this in a timely fashion and may entail other obstacles. Appeals for facility underpayment have to be submitted within 30 days of discharge. Pay attention to RAC demand letters by sending in supporting documentation and your reasons for explaining why the services were different than usual. If you don't return this documentation, the RAC is entitled to the repayments based on missing documentation. In tandem with reviewing the hydration documentation, make sure that you're also reviewing for any other duplicated charges that may have occurred. For untimed codes, excluding modifiers KX and 59 is one of the popular target areas. Make sure that you're billing 1 unit per data service. Another target area are once-in-a-lifetime procedures, which should be billed just once in the beneficiary's lifetime. Another common source that's overlooked are pediatric codes that are billed for patients who exceed the age limit defined by the CPT code. These problems often arise with the age crossovers from a baby at 30 days moving from newborn pediatric codes to infant codes, and again when the child reaches age of 1 and crosses over to child codes. Once-in-a-lifetime procedures are so called because you should report them just once in the beneficiary's lifetime. This puts G0389 claims under scrutiny because the code represents a one-time AAA screening for Medicare patients referred following an initial preventive physical examination. You can keep future claims clean by following the rules. For example, for Medicare, to cover the code, the patient must meet one of the following risk categories. Has a family history of aneurysm, is a man aged 65 to 75 who has smoked at least 100 cigarettes in his lifetime, or is a beneficiary who manifests other specified risk factors. Transmittals about the code often carry these kinds of specifics. A facility receives payment for the X-ray service through the prospective payment system's lump inpatient payment. Therefore, the radiology codes must be split billed using modifier 26 for an inpatient physician service. Facilities should not bill for the technical component with either the global code or the modifier TC appended to an X-ray code. In any setting, if you're billing for the radiology physician component or the radiologist's work of reading the X-ray and interpreting it, including a report, you bill Part B for the professional service using modifier 26 on the radiology code to indicate you're billing for only the professional component of the service. If the facility coder doesn't split out the professional service, the facility is overcharging for the physician service for double dipping. Don't worry, however, you're not missing out on payment. Since the inpatient payment system includes the radiology service or TC portion, you're already getting paid for both portions, which equals the total global payment rate. Remember this equation. 26 plus the TC rate equals the global rate. In other words, if you take the fee for the modifier 26 portion of a radiological TC 26 split service and add the modifier TC portion for the same service, you get the global total for the service. In other words, the global code comprises the total value of providing the physician service and equipment portion. Data mining equipment can easily spot global billing of radiology codes by a facility. So be vigilant about checking if your facility is making this error, and if so, correcting it through voluntary disclosures and implementing an education protocol to address the issue. DCS has a policy in place where its computer editing software detects radiology service charges billed with modifier TC on facility claims. Upon receipt of such a claim, past history of paid claims for that beneficiary are checked. If the date of service for the TC radiology service falls during the beneficiary's inpatient stay from admission to discharge date, the system issues an unsolicited response and the carrier adjusts the TC of the radiology service and issues a recoupment request. The RACs are going after more than just facilities. Two RACs, Connolly Healthcare and Health Data Insights, have their eyes on outpatient therapy, particularly untimed therapy codes. Connolly Healthcare website indicates that providers should enter only one in the unit billed column per data service. An example of an untimed code would be a PT or OT evaluation, such as 97001 or 97003. The RAC also mentioned that it would not consider modifiers KX or 59 in these CPT codes. While Region C consists of several states, Connolly will target its efforts in South Carolina. Health Data Insights will target claims in all 20 states under its authority. 3 of the 4 RACs have published untimed codes as an improved issue for automated review. In an automated RAC review, computer data mining programs look for claims in which a particular code has been billed in units of more than one. An untimed code, according to the CPT code definition, is one billed irrespective of the time spent on the service. In other words, if you don't see a time indicator, such as 15 minutes, 1 hour, 90 minutes, in the CPT code descriptor, you're looking at an untimed code. The therapy documentation may include the number of minutes, which could mislead a biller or coder who is unfamiliar with the codes into billing per increment. And if the MAC or fiscal intermediary system pays the excess units by mistake, then you'll have an overpayment. So therapists should alert their billers to this potential snag. In the RAC demonstration program alone, RACs recovered $3.2 million on the issue of speech therapy untimed codes. Speech-language pathology has the most commonly used untimed codes. Speech-hearing therapy and swallowing therapy are examples of two. Additional examples of untimed codes for physical therapy include electrical stimulation for stage 3 and 4 ulcers and paraffin bath therapy. Also keep in mind that most rehab therapy evaluations are untimed codes no matter how long the evaluation took. The only exceptions are some timed evaluations for SLPs, such as 96105 for assessment of aphasia and 96125 for standardized cognitive performance testing, which are both per-hour codes. OTs can report 96125 also. It's not just the codes themselves you need to watch. Modifiers can spring a rat trap too. For example, Medicare allows you to use the modifier 59 to identify situations where you provided therapy to more than one body site, but you can't apply a modifier 59 to an untimed code. Even if you're following all the rules, beware of the mistakes on the RAC's end too. Some providers in Florida had Part B therapy claims denied because claims had two untimed codes appearing on the same claim. Yet there is no prohibition against billing two untimed codes. The approved RAC issue is to look for 2 units of an untimed code. Florida providers are appealing those denials. An example of an acceptable claim could be a speech swallowing evaluation and a speech swallowing service on the same claim. And if your RAC comes after you for a claim like this, stand your ground and appeal. VCS is overturning automated reviews of untimed codes in RAC Region A that were conducted over the past several months. Letters were mailed to affected providers the first week of February 2011 with notification of the incorrect edit resulting in the overturned automated reviews, according to the provider notice dated February 16, 2011. DCS is working closely with the MACs to ensure any recouped overpayments are adjusted appropriately. The adjustment may take up to 4 weeks. Providers should receive a remittance advice that will show reason code N432 for the repayment of any related recouped payments. The notice asks providers to allow time for adjustments and indicates that since the overpayment is being rescinded, you may choose not to appeal the overpayment. If code J2505 is billed with more than 1 unit per patient per date of service, expect automated review to reject your Neulasta units. Pay attention to the quantity in the descriptor for J2505. It indicates 6 mg. Prior to January 1, 2004, Neulasta's code descriptor indicated you should report 1 unit per 1 mg, but the current definition requires 1 unit per 6 mg. The OIG 2009 report, Review of Medicare Part B Claims for Neulasta, Wisconsin Physician Service for the calendar years 2004 through 2007, revealed that WPS overpaid $655,149 for 462 claims submitted over the 3-year audit period. Neulasta, also known by its generic name pegfilgrastim, is a chemotherapy drug that was previously billed using Q4053, which referred to each unit size as 1 milligram. The code was then later changed to J2505, which defined each unit as 6 milligrams. The conversion may have been the root of many coding problems because some practitioners were simply accustomed to reporting 6 units of Q4053 and never made the conversion to reporting just 1 unit after J2505 was introduced. The carrier did not have sufficient edits in place during 2004 through 2007 to detect and prevent payments for such erroneous claims, the OIG report indicates. After 2007, providers were subject to CMS's medically unlikely edits, or MUEs, which have caught some of these unit coding errors. RAC overpayments will recoup the additional excessive unit billings. Starting on slide 26, not take me there for some reason. Starting on slide 26, I've included the links to the numerous resources that I turn to for information on RACs, MIPACs, and ZPACs. The CMS manuals hold the guidelines you'll need to refer to for staff education. With many RACs identifying 21 to 30 plus issues, this 30-minute presentation could cover only 5 areas. To view your RAC's complete issue areas, follow the hyperlinks on slide 30. With our limited time, we will not be taking questions today. SuperCoder subscribers can submit their queries on SuperCoder's forum page. CPC-certified staff moderators answer queries within 24 hours, Monday through Friday, 9 to 5 Eastern Standard Time. You can also email me directly using the email on the title slide. Please be patient on my response. I typically receive 200 to 300 emails a day, so it does take me some time to get to everyone. Now you can sort out your RACs, MIPACs, and ZPACs. And while not as satisfying as a warm bowl of alphabet soup, you can rest assured you're on top of your group's risk areas. Join us next month for Deborah Dorton's HCPCS 2011 update for oncology and hematology coders. Thank you for attending today's webinar, brought to you by SuperCoder.com, and please check your emails for your AATC 0.5 CEU certification from this webinar.